I'm going to go ahead and introduce our next speaker from the panel table here. We are extremely fortunate to have Dr. Roneet Lev. We are going to see a video from her. Since she was unable to actually be physically with us in the room, she is the Chief Medical Officer for the White House Office of National Drug Control Policy. She's charged with providing medical leadership in coordinating drug policy across the federal government. While working on national health policy, she continues her boots-on-the-ground experience of over 25 years as an emergency physician treating the frontline cases of addiction. She's board certified in both emergency and addiction medicine, and was the chief of the emergency department at Scripps Mercy Hospital in San Diego. In 2012, she established and chaired the San Diego Prescription Drug Abuse Medical Task Force, the first of its kind in California, that integrated physicians of various specialties and practice settings, along with hospitals, dentists, and law enforcement. Dr. Lev's medical publications, known as the Death Diaries, studied the details of prescription patterns of people who died from accidental prescription drug overdoses, giving insight to the causes of overdose and directing prevention efforts. So with that, I'd like to ask that we run the tape.
Thank you so much for the invitation to be part of this webinar and conference across the country. And congratulations on the kickoff event for Building a Movement. Building a Movement is a wonderful title because it'll take a movement to make a difference in addiction, medicine, and overdoses across the country. A movement of healthcare, of law enforcement, of prevention, of faith-based organizations, of criminal justice, of government, and the entire community. And it'll happen at home where you live and raise your children. A little bit about myself. I am an emergency physician of many years. I previously have been the director of the emergency department at Scripps Mercy Hospital in San Diego, and I've been working with my community locally on the issue of safe prescribing and opioid epidemic for over 10 years. I helped the San Diego Coalition and various coalitions around California and around the country in getting together the people on the ground, the people who are making a difference to make their own communities where they live, where they raise their children, to be safer and better. And that's what's brought me here to the White House, and now I am the Chief Medical Officer for the Office of National Drug Control Policy. I work here on health policy and still commute to San Diego each month and see patients and then apply that knowledge of boots on the ground to here at the White House and working on health policy. There's a reason and a passion to this work, as most people that I meet that are working in this field, that's personal to them. It's personal to me, it's personal to Director Carroll, to the President, and to many of you. For me, the child who touched my life and changed it forever is Aaron Rubin. He was a high school student who went to the same high school as my 4 children and succumbed to an overdose of Percocet. He did not die, but it left him a paraplegic. He can now only sign 1 for yes and 2 for no. And he took this tragedy, him and his entire family, to go out to the public to educate and make sure that that does not happen to other people. And now I want to give you some background about ONDCP. Our agency is part of the Executive Office of the President. Director James Carroll is confirmed by the Senate and is a primary advisor to the President on drug policy issues. Director Carroll is passionate about this work and brings the mission of saving lives to our entire staff at ONDCP. ONDCP is charged with coordinating drug policy across the federal government. We have budget oversight of the agencies that are involved with issues relating to drugs. This includes expected agencies such as National Institute of Drug Abuse, SAMHSA, DEA, and Health and Human Services. But it also includes agencies that have more indirect relationship to drugs, such as Department of Transportation, Department of Homeland Security, Labor, and Treasury. Overall, there are 16 and soon 18 federal agencies whose budget is controlled by ONDCP. The President's 2021 budget will include a record $35.7 billion to address every aspect of the addiction crisis, more money than ever to support this mission. ONDCP drug policy is guided by the National Drug Control Strategy. The strategy is focused on prevention, treatment and recovery, and reducing the availability of illicit drugs. This year, in addition to publishing the traditional strategy, our office published a historic national treatment guideline. The treatment guideline includes 3 pillars, 22 focus areas, and 6 factors. This sets a framework of the federal government as well as to you, our stakeholders, to bridge the addiction treatment gap. The pillars are improving early intervention, treatment recovery and infrastructure, improving delivery systems and providing efforts for substance use disorder, and improving quality in treatment. We very much count on a federal, state, and local approach to addressing the vast aspects of addiction. We will soon be working on voluntary consensus standards for addiction treatment. This will be a historic project with the medical field, and you will be hearing more about this in the future. Within ONDCP, we have a public health education and treatment task force. This task force provides strategic direction and guidance to interagency efforts to plan and manage the public health aspect of the National Drug Control Strategy. We have several projects at ONDCP Public Health Education and Treatment, and they include primary prevention, recovery support, substance use disorder treatment workforce, criminal justice intervention, and prescriber education. The need for addiction treatment is shown by the data from the National Survey on Drug Use and Health. In 2018, 21.2 million Americans needed treatment for a substance use disorder that included alcohol and drugs, and yet only 11.1 received specialty treatment. This defines our treatment gap. There has been a national alert on the volume of opiates prescribed by the medical community. This slide from IQVIA Institute shows that opioid prescriptions peaked in 2011 in terms of morphine milligram equivalents, or 72 pills per adult American. We must remember that there was a national push in the 1990s to address pain and to use opioids, and the medical community responded. Now we see the effect of the medical community responding to the opioid crisis. Since 2011, there has been a 43% decline in opioid volume, and 2018 showed the largest single-year decline in prescription opioids in history at 17%. Since 2011, there has been a 43% decline in opioid volume, and in 2018, we saw the largest single-year decline in prescription opioids in history at 17%. While opioid prescriptions have gone down, how has this correlated to mortality? Total opioid mortality from medications has gone up. This includes all opioids available by prescription and includes hydrocodone, methadone, and fentanyl. It excludes heroin. On the right of this chart, the circles show the division of opioid prescriptions, pseudo or synthetic opioids other than methadone, and the overlap of the two. You see how the total number is driven by the red circle, pseudo, synthetic opioids other than methadone, which is overwhelmingly due to fentanyl. Over 90% of pseudo is fentanyl, and the overwhelming majority of this fentanyl is illicit, not from prescriptions. The yellow bars in the graph represent prescription opioids that exclude any pseudo or fentanyl. This shows a rise peaking in 2011, followed by a decline. The mortality due to prescription opioids that exclude pseudo or fentanyl has declined along with prescription decline. But let's take a look at mortality due to unintentional overdoses from all medications that exclude illicit drugs. As we, the medical community, where should we be? The President's State of the Union highlighted an increase in life expectancy for 2018 to 78.7 years. The opioid epidemic hit our nation hard to the point of decreasing the life expectancy in the past few years. It's nice to see the needle moving in the right direction, but we are still lower than 2014 for life expectancy, which was 78.9 years. The CDC reported a decrease in overdose deaths by a rate of 4.6% from 2017 to 2018. The total was 367 people who died, down from 70,237. Our big threat remains fentanyl, with an increase of 10% in deaths from 2017 to 2018 related to pseudom, synthetic opiates other than marijuana. When I look at mortality data, I'd like to differentiate the supply chain. Everybody who dies from an overdose is our patients in terms of preventing addiction and treatment. But as far as supply chains, there's two different ones. The illicit market of heroin and methamphetamine and drugs that are pouring from outside our country and within, as well as the medical supply chain. If you look at the red bar, you'll see the medical supply chain, and those were started to peak in 2011 and includes all medications. It includes opioids, benzodiazepines, and various medications. And I suggest that the medical community focus on the prevention efforts on this red bar. And to do that, we need to think about opioids as well as all medications, all central nervous system medications that work together and increases the chance of accidental overdose. This slide is from a study I conducted in San Diego looking at all accidental deaths caused by medications, not illicit drugs. The colors show the various medications that are involved. While opioids are number one, the red ones, you could see that there are many other medications. But close behind are the blue color, benzodiazepines, as well as sleep medications and stimulants. All these are a factor and work additively to increase potential for overdoses. That's why when we talk about safe prescribing, we need to think about multiple medications and multiple prescribers that need to give coordinated care. There are many aspects, as I mentioned, to safe prescribing. The federal government has provided some important clinical tools, such as the CDC opioid guidelines, the Health and Human Services tapering guidelines, the FDA REMS education, support of the PDFP system, naloxone recommendation. I currently lead the ONDCP Safe Prescribing Work Group, and we are focused on the concern of concurrent CNN depressants, such as opioids and benzodiazepines. There's a high percentage of opioid deaths that include benzodiazepines, and recent studies show that the combined prescription practice remains an opportunity for education. Another public health priority is increasing access to medication-assisted treatment. You may have heard that the National Institute of Drug Abuse and SAMHSA are sponsoring a $500,000 a year grant on research called the Healing Community Studies. This grant is awarded to 4 states, Massachusetts, Kentucky, New York, and Ohio, with the goal of decreasing overdose by 40% in 3 years. Since we're talking about building a movement and focus on communities, I encourage local coalitions to look at the communities that heal intervention. And even if you're not one of those states that are awarded a grant, you could still use those similar tools and models. Another project that we are working on and is critical to the addiction crisis is building up the addiction medicine workforce. Out of 1 million doctors, only 5,000 are addiction medicine doctors and psychiatrists that are credentialed to provide that care. It may be 5,001 since I recently passed my addiction medicine boards. To put things in perspective, we have only 59 fellowships now of addiction medicine across the country, with the goal of 125 addiction medicine fellowships in order to build the workforce and infrastructure we need to treat our population. Another project, an innovation at ONDCP, is shared with the Department of Homeland Security and the National Security Council, and it's called Community Response to Drug Overdose, or CREDO. This is a project about linking in the work by the medical community and healthcare, law enforcement, and prevention together in order to save lives. Let me share a story from our emergency department. The other day, I was working and received a patient by the paramedics who came in with severe agitation after getting a dose of naloxone. In California, we have a big problem with methamphetamine, and the teaching point is that patients who come in with a potential overdose may not have the classic pinpoint pupils and sedation because they have mixed drugs on board. My patient required to be intubated and be placed on life support because he was not breathing well. I did a urine drug screen, and it was positive for cocaine and marijuana, but negative for any opioids. I was able to add a urine fentanyl qualitative test, which was positive. And he went to the ICU, and that could have been the end of my involvement with this patient. But I had a third-party responsibility, realizing that whatever he took may be exposed to other people in the community. And I was able to call our Overdose team, which is a group of law enforcement that responds to overdoses. They are specially trained in doing that in order to save lives. By doing that, they were able to come to the emergency department and identify my patient. He came in as a John Doe. They identified him. They were able to connect him with the family. They were able to go to the scene and talk to people, and they found 3 other people who were suffering from chest pain after taking this pill that they thought was a Percocet, but turns out to be fentanyl. The law enforcement agents have a mass spectrometer in the back of their car and were able to test the pill and tell almost immediately that this was fentanyl. Those 3 people came to the emergency department, and while I started with 1 patient, I ended up with 3 other ones who were having chest pain and was able to treat them. And not only that, the officers were able to take and eliminate the supply of that illicit fentanyl and save countless lives. So by working outside the traditional silos, partnering with other people in the community, instead of saving the 1 life that was in charge of me, that I had in front of me at the time, it turned out to save 3 others and maybe countless others by eliminating that source of fentanyl. Think about if I had a case of 3 people who came into the emergency department with diarrhea from a single restaurant. I would want to call public health and find that source of potential salmonella and romaine lettuce or whatever is causing that and eliminate that threat. I think that we should think along the same lines when we talk about overdoses that are even more lethal. I really want to thank everybody who is working on the ground in building a movement. You will be the ones who will make the changes that are necessary in your local community. And I thought about some tips that I would have about building a movement. And let me share about 5 tips that I was thinking for you. Number 1 is to find the resources you have in your own backyard. You have them. You have the medical community, the law enforcement community, the faith-based community, the criminal justice, the government. You have everywhere across America the components that are important to create a coalition and to create a movement. That's tip 1. You have those resources. Number 2 is to take those people and break the silos. While we each work individually in our own lane, the real solution would be cutting through those silos and working together and sharing information, and you will enjoy that work because you'll be inspired, but you'll also make a bigger difference. Number 3 would be to use the face of addiction. Each of you have people who have been touched by this epidemic, who have died or are in recovery, and use their voice. It is very powerful in making the clinical or health policy points that you need to make in your community. And tip number 4 is to think outside the box. We've put a lot of tools in front of you that can be used and suggestions, but working locally and thinking creatively, you may come up with something new and even better and use that. In my community, I said, I'm going to write prescriptions for naloxone to anybody who has them and pass them around just like the pharmaceutical industry did to me 20 years ago in giving me free written prescriptions for opioids. There's a lot of innovations and use your creativity. And finally, celebrate your successes. You can try many different projects. Not everything works, but when something does, celebrate that as a community, and together you are going to, make America great and safer. And again, thank you so much for what you do every day and for building a movement.